On this, we're going to run through what I've already covered for our medical students, initially with the die or say something interesting to please mnemonic, and then we'll go into some of the specific questions that you could be asked about ACL injuries for the FRCS. Sports injuries in the knee are a massive topic. You can have complete, let's say, topic-centered approaches for one whole conference on the ACL and sports associated injuries. But remember, obviously for this, you're going to be talking about this normally in a 5-minute to 6-minute Viva. So then we're going to focus on the most common kind of topics that you'll be asked about. I would recommend you read about these and read around the topic a little bit yourself as well. But generally speaking, I'm trying to cover as much as I can that would be fair game, but also easily retained and very common topics around the ACL itself. So the definition of it, we don't need to cover too much. It's disruption or rupture of the ACL of the knee. And then the incidence of this, it depends on what you read. 400,000 per year in the US, or again, some papers will tell you that it's between 8 and 52 and 100,000. But ultimately, the way that I think of this is 1 in 3,000 have an ACL injury per year, generally speaking. The etiology of it, I think, is a very important thing that's overlooked. It's actually a non-contact injury. It looks like it's contact at the time of the injury because it will be in a sidestepping movement. You won't be sidestepping unless there's an opponent in front of you. And then what happens is you sidestep them, they lunge, they catch onto you, but actually you've injured your ACL in that directional change before your opponent lays a hand on you. So it is something to be aware of, that between 70 and 80% of these cases are actually non-contact. But also the pathobiomechanics of it is important. So it's valgus force with the foot planted, can be running, can be landing, and also with internal rotation of the tibia. If we move on to the signs, the effusion, bruising, and blocked extension are early signs, and this will normally be because of the effusion that's stopping them from getting to terminal extension. They don't have a solid block to extension. There is no physical block, and the ACL rupture itself doesn't act like a block in the notch. So me saying that it's a blocked extension, what I mean by this is that it's a soft block, primarily because of the effusion in the suprapatellar pouch. They're unstable on special tests, anterior drawer, Lachman's and pivot and valgus stress, but again, be prepared to be pushed on your valgus stress test. If you have valgus opening in extension, it means that your MCL is actually involved as well. If you only have valgus opening at 30 degrees of flexion, then that's your ACL in isolation, but you shouldn't be able to have valgus gapping on the medial side with an intact ACL if you don't have an MCL injury as well. So there's an issue with this. So you need to be sure that you know what you're speaking about and the questions that you're being asked. And also remember that the posterolateral bundle is tight in extension. So if you're gapping then at that point, then the MCL has to be involved at that point. Symptoms generally pain initially, but this is actually a pain-free condition. So normally when they'll come to you in the clinic in a few weeks after the injury, they'll actually be pain-free, but they will sometimes say that I've got intermittent swelling and I've got instability primarily in coming down the stairs because the femur with gravity is trying to translate on it moving backwards, but also then that in turning is a big one. And sometimes you'll have players who have gone back and they've decided they want to keep playing, and the rotational instability is something that's stopping them. So straight line running sprinters don't need an ACL. People going around a bend or directional change, and then the risk of instability is higher with the higher the incidence of pivoting in the sport. So netball, basketball, volleyball, tennis, they're very high pivoting sports with sudden directional change at 180 degrees of the direction you're moving in. Investigations, you should be able to diagnose the ACL from your clinical examination and be sure that you understand and can reel off your sports knee examination if they're not allowing you to actually perform it. But the MRI then is being done. It's the gold standard for soft tissue injuries, but what you're also looking for is your pathognomonic pivot shift bone bruising pattern. You're also then trying to rule out any other soft tissue injuries which would have to be dealt with at the time of surgery. So for instance, a Stenner lesion on the MCL or a meniscal injury, more so on the medial side because it's less mobile and it's also attached to the capsule and the MCL. But remember as well that there is a better outcome with meniscal repairs in the setting of an ACL reconstruction. And also the ACL reconstruction has a lower failure rate when you actually deal with the meniscal pathology at the time. Treatment itself, there is some talks of repair, but only in pediatric cases. But generally, this is something that you'll see when you have a tibial spine avulsion. So therefore, the ACL itself is intact. It's an avulsion type pattern, and then it's treated like a meniscal root, where you drill a tunnel, retrograde in the tibia, put a loop around the base of the ACL, and dock it into where it belongs. That is not an ACL repair as such. That's a tibial spine avulsion, and be careful not to get caught out by this. Non-operative management is an option depending on your patient selection. So if they're non-elite athletes, they're older and they're arthritic, then you have to have a conversation with them about the risks and the rehabilitation burden that you're going to put on them if you reconstruct their ACL. But excluding those patients, then it is reconstruction, it's not repair. The prognosis then, generally speaking, is worse for females, worse for younger patients, and therefore combining these, worse again for younger females. Otherwise, it's good, but this really depends on their commitment and their compliance with their rehabilitation. And the timing of this is something that's quite interesting. There's a big push towards not operating on these patients too early. And if you look up the Melbourne rehabilitation protocol, they break it down into 5 or 6 stages, depending on the way you look at it. And the first stage of this is restoring full extension and starting with getting the swelling down, and also getting gluteal control and quadriceps pre-activation before surgery. This MRI might be something that might be popped up in front of you, and this is pathognomonic of an ACL injury, because by definition, this is a transient subluxation or a transient dislocation of the knee that has then relocated. And there is no way to have this bone bruising and also this small little kind of divot here. The cartilage is intact, but you have bone bruising on the femoral side and then posterolateral bone bruising on the tibia here, which is your pivot shift sign. And by definition, that is pathognomonic of an ACL injury. This x-ray is also one that you might be more likely to have, and they might actually show you this first. And this fracture would be eponymously known as a second fracture. Be careful what you refer to as the actual donor site of this, and they might say, oh, it's the LCL attachment. Well, the LCL attaches onto the fibular head. So therefore, if this has avulsed off of here, then it's very unlikely to be the case, because then you'd expect more gapping depending if this is dynamic or not. Segond himself described this fracture, and the Segond finding of the ALL was actually found in 1867. So I think in looking back over all of this, you are safer in saying that this is a lateral ligamentous complex avulsion, eponymously known as a second fracture, and has a high correlation with ACL injury. I think it's between 75 and 80% depending on the paper you read. Be careful not to dig a hole for yourself, and don't say that, oh, this is definitely the LCL. It may not be the case. And you're keeping yourself nice and general and saying this is an avulsion of a partial lateral complex or lateral collateral complex injury or capsular complex injury as well. You're not committing to definitively saying it's the LCL. Specific considerations for these then would be the younger patients do far worse, and by younger I mean under 17. They have a higher incidence of repeat rupture. Females have a 4 times greater incidence, and the question of this is often discussed, and why. So bony anatomy is sometimes mentioned, their abduction angle at the knee, their Q angle being higher, or their pelvic size being bigger. And there's a lot of evidence that suggests that that isn't the case. There's also talks of the notch being smaller, and yes, female notches are smaller than male notches, but you can have females who have bigger notches than males depending on your standard distribution of the population. So again, we have to be careful about this. There's a lot of research around the hormonal changes and the menstrual cycle with regards to ligament laxity. But again, there's nothing kind of concrete on this, and I believe that Bath University are doing some work on this as well, and there were 2 studies out of New York a long time ago that both contradicted each other, and again, we're not really sure if this is the case or not, but anecdotally, there is a lot of suggestion around this being related to hormonal changes. Some stuff that is definitively proven is neuromuscular control. The female patients engage their quadriceps earlier than their hamstrings in deceleration, which therefore in a flexion moment arm actually pulls them forward. So I know that the quads would normally pull the tibia as well forwards as it's in extension, but even with the moment arm as well, with the hamstrings engaging later in flexion, the quadriceps pulls the tibia forward at this point. Later entry to sport is often mentioned in the literature. I'm not really sure if this is something that we can truly say as an objective finding, but generally speaking, females end up entering the pivot high-risk sports much later. For instance, rugby, most females that I've worked with who enter high-level rugby actually never played it until they were 15, and this is because female-specific sports, or rather teams, aren't available at the younger ages. Netball, again, is something that's very high-risk because of the very fact that you are running at speed and then suddenly decelerating when you have possession, and it's the exact opposite of many other sports. And then higher risk sports, like we've mentioned, volleyball, tennis and basketball are also high pivot risk sports. The management of this would be timing, as I've mentioned already, and it's something that to talk about what you're looking for. Ultimately, you want to make sure you get full extension. Full extension is vital because flexion is a risky position, subsequently followed by valgus and internal rotation. The next thing that you could talk about, if the conversation is going well, is your graft choice. And firstly, talk about autograft, allograft, synthetic, or combination. So the autograft can be broken down into bone, tendon, bone, hamstring graft, or quadriceps tendon, and there's lots of stuff to read around this. Bone, tendon, bone has the best performing revision rates across any form of publications, especially from ISCOS over the last 20 years. Bone, tendon, bone is the best performing graft. Despite this, a lot of them are still performed with hamstrings, and I think it's because we're far more confident with doing a hamstring graft and also in proceeding with these rather than taking the bone harvest. A lot of the time it depends on the position for the player, and if they are a kneeling player, for instance the front pack or the front row and second row of a scrum versus being a fullback in rugby. And then the worry is that if you take the hamstring in patients in the back and who are playing, let's say, a centre, wing or fullback, then you're taking away their sprinting power. So there's some discussion around this as well. There's a big push towards quadriceps as the index graft. It's previously been mentioned a lot in Korea as a revision graft choice, but I've met a number of patients from Singapore and Korea who have had it done as their primary graft choice. And I've also met a number of surgeons in the UK who now use it as their go-to primary graft of choice. Allograft from the literature is bad, but this is because it was irradiated, and lots of very good research out of Korea from this perspective. Now that we have the likes of BioCleanse, which doesn't use irradiation, then there is a lot of suggestions that allograft is a better option for this. Now, you have to remember, if you've got an older patient who's already tendinopathic, using bad quality tendon from themselves, just because you're avoiding using allograft is questionable as well. So that can be a very valid point of discussion. But just remember, there is no right or wrong answer from this perspective. Synthetic only is just bad across the board. It's failed in animal models. It's failed in animal non-research based and let's say true clinical trials and true clinical uses. And it's failed in humans as well. Combination, however, with autograft and synthetic is something that's used a lot. And you'll hear people talking about the BioBrace, the bracing of the ACL graft itself with synthetic suture tapes or different other kind of nylon tapes as well. The question with this then is, are we stress shielding? Are we preloading the synthetic material and not the graft? Or are we just putting in the graft and the graft is taking the load, but the synthetic stuff is only going to act like a foreign body, or let's say delay integration into the bone tunnels? We don't really know if this is true or not and where the issue of this lies. Should we be preloading the synthetic graft? Should we be working purely on the softer tissue as well? And this is a big question. So lots of reading around this would be certainly advised. But again, like all of these, if you're talking about this in your exam, you're doing incredibly well. So don't worry about the nitty gritty. Even if you're super interested in sports surgery, make sure you keep your breadth of knowledge broad, so to make sure that you're covering your maximization of points across all the other options of point scoring opportunities during the exam. Augments is a very interesting conversation as well. The stability trial in the UK is an interesting read as well, depending on how you perceive it. The lateral extra-articular tenodesis, or an LET, is not protected to one specific technique, but the three most commonly performed techniques would be a modified Lemaire around 1967 in the literature, the Ellison, which was done around the same time, 1970, and the McIntosh side. So you've got a French side, you've got the Americans, and you've got the Canadians, all doing very similar stuff around the same decades. And Macintosh 1, 2 and 3. Macintosh 3 has been abandoned because of the repair versus reconstruction of the ACL, but again, that might come back into vogue. The lemare is where you leave the ITB attached distally and then tunnel it under the LCL and attach it to the back of the femur. The Ellison is the exact opposite. You leave it attached proximally, tunnel it under the LCL and attach it distally. And then again, the changes of this then are just augments of this. The anterolateral ligament we've already talked about with Sagond in 1879, and again he found that there was an increased tension with internal rotation of the tibia, and he found a glistening structure at the anterolateral aspect of the tibia. Now, again, the choice of patients for doing an augment, not every patient should have one or should need one, but high-risk sports, especially in high-level athletes, and generally you'll find it in pro athletes, we'll have a very low threshold for doing this to make sure that we don't increase their risk of re-rupture. Revision cases will generally get an augment. Increased tibial slope on a true lateral of the knee greater than 12 degrees will often prompt us to use an augment. Associated meniscal injury being repaired versus resected. So if you're looking for increased stability of the knee in allowing the meniscal repair to be improved, you will have a very low threshold for doing an LET. Females, especially high-level females, and also males younger than 18 years. The other stuff to remember then with regards to the associated injuries would be meniscal injuries, especially the medial side because it's tighter and more closely adherent to the tibia, but also to the meniscal capsular attachment. Meniscal injuries, better healing rates when associated with an ACL, and then the ACLs themselves do a lot worse if you ignore the meniscal injury. Multi-lig injuries, again, it's something that is very high level if you're going into this, but ultimately the MCL is grading dependent. Sometimes we will leave these settle and let it re-adhere itself, but if there's a Stenner lesion and it's lying superior or lying superficial to the pes, then you have to go in and reattach it. If you are going in the anteromedial side of the knee, this would be a very low threshold then for doing a hamstring graft, even in surgeons who prefer a bone tendon bone graft because we're already opening the MCL side. PCL is often non-operative, but then we have to keep the patient in flexion. So again, you have to talk about the staging of these, and when you do them, there is no rush with the ACL. So one very good option is that if we keep them in a little bit of flexion for the PCL initially to take the tension off it to allow it to heal, because it is intra-articular but extrasynovial, it allows it to heal. The MCL then we want to avoid valgus stress. Posterolateral corner then is often staged with the LCL, so then you can justify leaving your MCL provided there's no Stenner lesion, leaving your PCL for the rough time period of between 8 and 12 weeks, and once these are then stable, you will still do an EUA on table, but you'll consent them for this and you'll consent them for a reconstruction, and then what you can do then is possibly re-image them and see how they're doing. Then consider the posterolateral corner, the LCL, and then the ACL itself at that time. So beware that you will be able to talk about a lot of these, but if you're talking about these, you're doing incredibly well at that point of your exam. Before we go any further on this side as well, I do want to talk about the increased re-rupture risk. So if you have a female patient under the age of 17, there's a lot of evidence that suggests that she should avoid contact sport until she is 17. And then at this point, you drop from about 50 to 55% re-rupture rate back down to a quarter and further less. The re-rupture rate continues in all patients, in all players, no matter what gender or what age, up to the point of 18 months post-op. So we generally don't allow them to return to contact sport until about 11 months. But again, it depends on their sport of choice. And it also depends on then how likely it is that they're going to injure it as well. Female patients have a higher risk of contralateral injury after having surgery on their ipsilateral side. And then it also depends on what you're dealing with as you're going along with how risky this is. And it depends on whether they were lax to begin with, do they have any other ligamentous laxity, any other revision causes, any other associated injuries, and their risk of sport.